안녕하세요. Yes, hello. I'm Toru Kameda from Japan. Thank you for your invitation and the collaboration between the Society of Emergency and Critical Care Imaging and Japan Society of Point of Care Ultrasound, what we call JPOCUS. Dr. Yamada scheduled to come here. He is very looking forward to coming here, but he faced a physical issue. Instead of him, I came here. Dr. Yamada, right side. Basic urinary tract POCUS is one of the core clinical skills for emergency physician. After the resident masters the basic skill, advanced or new knowledge related to the urinary tract ultrasound may help them improve patient care in emergency department. I talk about point of care ultrasound related to the urethrolysis and pyelonephritis, difficult urethral catheterizations, and pocket-sized US device. I talk about point of care ultrasound in urethrolysis, hydronephrosis. All emergency physician and critical care physician evaluate the presence or absence or degree of hydronephrosis, and stone in the ureter, twinkling artifact on color Doppler, and peripelvic extravasation of urine. POCUS help us realize the presence and degree of hydronephrosis immediately. It's an indirect findings of urethrolysis. Many studies performed, diagnostic performance of US performed by emergency physician. And CT was used as a reference standard. And sensitivity 65 or 87, and the specificity 73 to 83, like this. Based on 5 studies, meta-analysis was performed recently, and poor sensitivity is 70. And specificity is 75, not so high. But why do we use ultrasound for evaluation of urethrolysis? Several papers show us the usefulness. Very famous studies in New England Journal of Medicine, large multi-center randomized trials was performed. Nearly 3,000 patients who present to the ER with suspected nephrolithiasis were assigned to POCUS, radiology US, and CT. The incidence of high-risk diagnosis with complication in the first 30 days was low and not vary according to the method. The mean 6 months cumulative radiation exposure was significantly lower in the US groups than the CT groups. This is one reason to reduce radiation exposure. Why we use ultrasound for evaluation of urethrolysis in ER. The other study published, Korean doctor published, the use of early bedside US for patients with acute flank pain could reduce the ED length of stay without increasing expected ED revisit. I totally agree with the ideas. Next, stone evaluation of stone in the ureter. Under some good conditions, we can detect a stone in the ureter, especially at the uretero-pelvic junctions here, or the uretero-vesical junction. Some of the EP evaluates stones, not only the evaluations of the hydronephrosis. Let me show you the several cases. Yes, you can detect the stone, mild hydronephrosis. I always ask the resident to perform the ultrasound before they ask the patient to void for urinalysis, because we need an acoustic window. Okay. This study is performed by groups. Grades of hydronephrosis, and here no hydronephrosis, minimal, mild, moderate, and the detection rate of urethral stone. In patient no hydronephrosis or minimal hydronephrosis, detection rate is not high, around 50s. But In patients with mild or moderate hydronephrosis, detection rate around 70s. Okay. Interestingly, UVJ stones were easily detected, even though the patient have no hydronephrosis or minimal, because we can use the bladder as the acoustic window. Next, I talk about the twinkling artifact on color Doppler. In the morning session, the doctor presents the twinkling artifact, right? I checked the brochure. The twinkling artifact or color comet tail artifact is characterized by a rapidly changing mixture of red and blue color Doppler signal, like this. If the image of the stone is unclear, the twinkling artifact helps us realize the presence of the stone with confidence. Could you raise your hand if you use a color Doppler for aberration, like this? Okay, thank you. Let me show you the several cases. I performed the ultrasound, and I'm not sure this is a stone or not. So I decided to use the color Doppler. So you can see the twinkling artifact with confidence. We realize this is a stone. Okay. Same patient with longitudinal view. Yes, if we perform the ultrasound with longitudinal view, we can detect stone easier. But with twinkling artifact, very evident. Okay. This is studies, sonographic diagnosis, symptomatic urethral calculi, usefulness of twinkling artifact. We have the evidence. Prospective study of 100 patients with suspected renal colic. US, including B mode, including color Doppler, detected 76 of the 84 confirmed lithiasis. Sensitivity 90, specificity 100, and total of 78% exam by color Doppler sonography show the twinkling artifact. Interestingly, 70% of the twinkling positive calculi show the artifact before the stone itself was detected. Okay. The other example, 46-year-old man presented to ER with lower abdominal pain at 6 o'clock a.m. 3 years ago. He suddenly lay down on the bed and performed physical examinations by himself, which revealed no abdominal tenderness. He asked the nurse to bring the portable US machine instead of asking her to call an EP. I'm not sure, he don't believe the skill of the performance of US. Stunning his pain, he performed US by himself to reveal the cause of the pain. He detected the left side of the kidneys, hydronephrosis, mild hydronephrosis. He wanted to detect the stone because he don't want to undergo the CAT scans. So he find, but he didn't have a confidence it is a stone. So he decided to use color Doppler with confidence. He find the stones. Okay. He is me. It's a true story. But I believe about my colleagues' skill of the ultrasound. It's a joke. How about self-checking point-of-care ultrasound? It's a new usage, I think. Okay. Next, peripelvic extravasation of urines. I always check around the kidneys. We can also detect some complication of urethrolysis, such as peripelvic extravasations, without difficulty, which indicates the presence of increased pressures in the renal pelvis due to obstruction of the ureter. Stereo image, minimal or mild hydronephrosis, and around the kidney, we can find the fluid like this, longitudinal views and transverse views, fluid. It's evidence of the increased pressure of the pelvis. Okay. Also, the mid-ureters stone was found. The other case, moderate hydronephrosis with extravasations, like this. But we have to distinguish between the ascites and peripelvic extravasation based on the distribution of the fluid. Okay. 50-year-old man presented with left flank pains, minimal hydronephrosis, but the kidney has fluid around the kidney. Yes, I think it's also a useful findings as a POCUS. Next, I talk about the pyelonephritis. Diagnosing acute pyelonephritis usually rely on the combination of history, physical, and laboratory finding, urinalysis. Imaging is not always necessary, but I always perform the POCUS in all of the patient. POCUS guided palpation. Do you know? Including the sonographic Murphy sign in cholecystitis, sonographic McBurney sign in appendicitis. How about renal sign? Toru sign? No. We have case series eliciting renal tenderness by sonopalpitation in diagnosing acute pyelonephritis. 3 cases, but the study indicated that POCUS-guided palpation may aid us in localizing pain in cases of suspected acute pyelonephritis lacking classic feature. I tried like this. Under the direct visualization of kidney, pushing with probes, and I realized the pain is confined to the kidneys. Such kind of usage is alternative options. We are not sure this sign is superior to severe tenderness. We need studies. Yes. Next, complicated acute pyelonephritis due to urethrolysis. Yes. Complicated acute pyelonephritis, such as obstructive uropathy due to urethrolysis, delayed management can lead to high morbidity and mortality. I have experienced 43 women presented to back pains and with fevers. Some emergency physicians diagnosed simple acute pyelonephritis, but in 3 or 4 hours, she developed septic shock with ARDS. Very sad stories. So after that, I always perform the POCUS. Once I diagnose the patient as acute nephritis. Yes. This study from China, Dr. Chen, our colleagues, retrospective studies, 243 patients diagnosed as acute pyelonephritis. Emergency US was performed 40%, and 40% had abdominal significant finding, such as moderate hydronephrosis, polycystic kidney, abscess, emphysema, tumor, distended bladders. And surgical intervention was performed in 46 of the 53. Very high rate, I think. Usually, after the doctor diagnosed as patient as acute pyelonephritis, we have to think next indication for initial genital urinary imagings. New England Journal, recent New England Journal Medicine indicates new eGFR decrease to equal 40 milli per minute 2, or known or suspected urethrolysis, of course. But in my opinion, POCUS is prevalent as all emergency physicians use POCUS. So all patients diagnosed as acute pyelonephritis with initial assessment all patient is deserved to undergo the POCs, in my opinion. Next, difficult urethral catheterizations. Difficulty in catheterizing male patient includes urethral course altered by benign prostatic hypertrophy (BPH) and several factors or other causes. In elderly patient with BPH, difficulty with standard urethral catheterization is occasionally encountered, and repeated and unsuccessful blind attempts can cause patient distress and damage to the urethra. For example, bleedings and patient shouting, no way, please stop, like this. Let me show the schema of the lower urinary tract, bladder, prostate, urethra, like this. This part is a point, especially in patient with BPH. If the patient, have the BPH, the course of the shape of the course of the urethra changed. Especially around here. I call this part posterior and bulbar urethra, PBU. From now on, I'll call this part PBU, okay? The PBU is normally like this, but patient with, for example, BPH, for example, the course of PBU, like this. I realize with using the ultrasound. Some causes of difficulty are considered to be related to the cause of the posterior and bulbar urethra, PBU. We assume that the possible cause of the PBU can be evaluated with transabdominal US and manipulated with transrectal pressure using the digital rectal examinations. This study performed by our groups. Let me show you the studies. Adult male patient in whom standard urethral catheterization failed or who were transferred from other facilities after the failure of catheterization and subsequent urethral bleedings. The enrolled patient includes those in whom the tip of the catheter could not be advanced through the PBU, judging from the inserted lengths, okay? First, for example, emergency nurse advanced the catheter until the progress was obstructed, like this. Next, physician placed the probe on the suprapubic region longitudinally, observed the possible cause of the PBU, and tried to detect the tip of the catheter, okay? To detect the tip more easily, the physician asks the nurse to oscillate the catheter gently and move the tip, like this, okay? If the tip was detected, the nurse withdrew several centimeters from the point of the obstructions. Then the physician then inserted the index finger from the free hand, one hand, the other hand, into the rectum and kept pushing the point of obstruction ventrally under the US guidance to make the curves of PBU become gentle, okay? Once more, like this. After these procedures, the nurse again advanced the catheter. Finally, the physician checks the presence of the tip in the bladder. That's the procedures, okay? Let me show you an example. 80-year-old man with past medical history of BPH, difficult urethral catheterization, past medical history, was transferred from the hospital because of unsuccessful exchange of indwelling catheter, subsequent urethral bleedings, and infravesicular obstructions. The tip of the catheter here, internal urethral orifice, here, my finger. before before pushing upward. Okay, so we can assume the course of the PBU like this. Tip, internal urethral orifice, that's why. After I push with index finger upward and catheter advanced smoothly, okay? This pilot study only includes 6 cases. 2014, this study was published. Successful with procedure in 4 of 6 cases. 2 cases successful without US procedure because one patient have agitated during the insertions. So we can't evaluate with ultrasound, only with rectal examinations with success. The other ones, bladder was too distended to visualize the PBU. The PBU moved downward. That's why ultrasound can't detect the PBU. After we finish the procedure, we continue to use this procedure. Recently, I experienced in 2 cases, and let me show you 2 examples. 17-year-old man with past medical history of BPH presented to ER with a complaint of difficult urinations. Emergency nurse and emergency physician tried to insert 14 French usual standard Foley catheter in the standard manners, but the attempt ended in failure with urethral bleedings. So my colleague asked me to do that. At that time, the urologist could not come to ER immediately. Internal urethral orifice here, the tip of the catheter. So the course of the PBU, you can imagine like this. Maybe some cases, prostate is, if prostates become bigger, like this. That's why, I think. Before insertion, before advance the catheter, my digital finger during the pressure upward. That's why the course of the PBU like this. Before transrectal pressure, sorry. Before transrectal pressure. After the transrectal pressure, the angle like this. After that, the nurse advanced catheter smoothly. Okay. Same situation. 1 week ago, I experienced the same situations. Internal urethral orifice here. Tip of the catheter. Oscillation like this. So index finger with index finger push upward. The course of urethra or PBU become gentle. Okay. I'm happy if you use such kind of procedure, and could you tell me your thought or your idea? Finally, I talk about pocket-sized US device. Several types of pocket-sized US devices are being developed during the past 10 years. PUDs have the potential to be used as an extension of physical examination owing to their portability. Could you raise your hand if you use a pocket echo in your daily practice? Which kind of situation? In ER or in ward or in ER? Okay. Our group performed the evaluate the assessment of renal correcting system using a pocket-sized ultrasound device. To assess the performance of pocket-sized ultrasound device for evaluating dilatation of renal correcting systems, we have several research related to the cardiology, but a few in the abdomens. One sonographer examined both kidney using a PUD pocket echo to evaluate the dilatation of the correcting system. Immediately after the examination, another sonographer, blinding to the previous result, perform a formal examination with a high-end US device. Grade 0, no hydronephrosis. Grade 1, minimal dilatation of pelvis. And grade 2, dilatation of pelvis with dilatation of the calyx. Grade 3 and grade 4 with cortical thinning. If definition of hydronephrosis grade 1 or more, sensitivity, specificity, positive predictive value, and negative predictive value. If the definition was grade 2 or more with calyceal dilatations, sensitivity, specificity, positive predictive value, negative predictive value. So negative predictive value is very high. Our team realized that. Number of each grade given with PUD and high-end device, pocket echo and high-end device. Grade of the hydronephrosis, pocket echoes, and grade of hydronephrosis, high-end device. So the weighted kappa equal 0.83. Very nice. So ultrasound using a PUD by skilled physician is considered to be useful for evaluating hydronephrosis, especially for ruling out its presence. Okay. I finished these disease or procedures. This is a conclusion. The advance to a new knowledge related to urinary tract ultrasound may enhance the quality of urinary tract focus. Thank you for your attention and collaborations.